like vaccines, then we cannot be able to do effective response to any a large outbreak. And finally, the sheer value of a national institution that is vested with the responsibility for health security is invaluable. Countries that had functional national public health institutes or national institutions did much better than countries that did not have. So these are some of the key things that we've learned on the continent during this pandemic, but there's a lot more in terms of lessons that we'll be sharing progressively throughout this conference. Thank you, Krishna.
Fantastic. Thank you for those really important lessons and also for such strong leadership. The Africa CDC has really been one of the bright spots of the pandemic response around the world, and in large part thanks to your leadership. So it's great to see this. Let me move next, Chikwe, to you, as you're thinking about how we've done, but also what we should think about for future priorities for health emergency preparedness and response.
Thanks, President. If you don't mind, let me move to the podium just to share a few thoughts. If we can have this, is it on? Yeah? Okay. So, thanks, and thanks, colleagues. First, just to say that in addition to my current role in WHO, I was privileged to lead the public health response in the biggest country on the continent. And a lot of these reflections will stem from that. So we struggled in many ways. One of them was in our ability to rapidly use data to make decisions, to have a coordinated process of collecting, analyzing, and using the data we had to enable our colleagues make decisions rapidly. And previously, like many of you would relate to, you know, if your minister called you to respond to a crisis, you could tell him, listen, I'll bring the data for you in 2 weeks or in 1 month. And now we're faced with a position where we had to respond on an hourly basis to demands on data. The second area is on the development of countermeasures. And my brother Ahmed just related to this. How quickly, how can we develop and use and deploy tests, vaccines, therapeutics to people that needed it? Do we have a manufacturing industry? Do we have a research industry? The third area of major concern is the clinical services. We've always really not included thinking around how we deliver on clinical services as part of our public health response. So generally we've hoped, yes, we'll manage the public health side of the outbreak, and the guys providing the clinical services will manage patients. But we found out that that wasn't sufficient, that we needed to think about how do you deliver oxygen, how do you deliver PPEs, and all of that are part of a public health response. The fourth area of real concern was what we now call public health and social measures. And that's an area, yes, you can deploy initially, but then once things got a little bit more difficult, it became increasingly more difficult to deploy. And the fifth, and probably the most important, and I'll get back to this at the end, is who does the coordination? And it's a question we really have to think about at a national level. So in WHO, we've been thinking for the past year on where did we not get it right and where can we do it better. We have assessed ourselves in depth, and this is something I really propose every organization here should be doing, to reflect yourselves. We had over 300 recommendations on how we could do it better. And through that, our DG, Dr. Tedros, who would really have loved to be here, has proposed a new strengthened health emergency preparedness and response architecture for the world. And this is what I'll spend the last 3 minutes offering us to reflect about and how we'll use this ourselves. But before that, to think that the two key things that will drive this is a change of governance and a change of financing. In the governance, all of us are represented by our ambassadors, and all of them are working right now on a new pandemic treaty in Geneva. Thinking, contributing, brainstorming on how do we agree as a world, as a global community, what commitments do we have to each other? Secondly is on the financing. And you'll see that there's a new pandemic fund agreed on, and all of us are agreeing on how to commit resources to pandemic preparedness and response. But even if we get the governance right and we get the financing right, we still need to think of what to do. And what are we doing? So a new framework that we're proposing, and our representatives will think about and talk about this at the World Health Assembly in May. The first is a new concept called collaborative surveillance, which is really expanding the definition of surveillance from our perception of it as just measuring disease incidence, morbidity, and mortality, to including all the new opportunities around genomics, around behavioral science, around migration, mobility, that we've used in the pandemic, but we're almost dropping again. So how do we include these concepts into a longer-term thinking of what surveillance means? The second is to think really around countermeasures. And you'll notice that there's a C in each of these to enable us to remember it a little bit easier. How do we think about the development of countermeasures from research to manufacturing to warehousing to distribution as part of the responsibilities of a public health response? The third area is on clinical care. Like I mentioned, we have to now incorporate our clinicians and our clinical leads in thinking on how to respond to a public health event, and not just hope that clinical service will deliver. And we've seen in many countries, in the most advanced countries in the world, how they struggle to provide sufficient clinical care to patients with COVID. And the fourth area is on community measures. And this is really where we have a strength on the continent, because whether it's the HIV response or all the other challenges we're responding to, we've always integrated the community into our response. And this really is an advantage for public health on the continent and something we have to learn from. And the final point I'd like to leave you with is on coordination. And this is really something we have to think about. How do we coordinate from the local to the subnational to the national to the regional to the global? And each of these levels are important, because if you don't get any level right, it compromises the response at all levels. So all levels of coordination are right. But in a way, the one I'd like to focus on most is the national level. Who is coordinating a national response? When we have a security incident, do we call the Ministry of Internal Affairs? If we have an external security incident in our countries, do we call the Ministry of Defense? No. We call the police, we call the army. So when we have a health security event, why do we think that we can rely on ministries of health to respond? That architecture simply is not equipped for an operational response that a health security event requires. We need to build the coordination capacity in every country that understands the modes of working, the modes of all the skills that we need to deliver, and has the accountability and leadership to deliver on this during a crisis. So I'll end by saying, in my team in Berlin, we are primarily responsible for delivering on the collaborative surveillance part of this, working with many of us to rethink what surveillance means, rethink what health intelligence means, and exciting conversations going on at the moment. I won't bore you too much with this slide, but the key thing is to know that this is not only about capacity, it's also about collaboration. So we have two axes that we have to focus on. One is building the capacity that we need in every country, but secondly, in building collaboration across countries, across continents. And the optimal state is there at the top, where there's optimal capacity and optimal collaboration. And even in countries, and we have seen this in every continent, where they thought they had a lot of capacity, but if there's no collaboration within that space, we don't get to the optimal state. So in the new process we're building, we're not doing it alone. And this is a commitment, it's a new way of working for the World Health Organization, recognizing from the very beginning that to do this, to prepare for the next pandemic, we need to do it together. We need to do it together across the world. We need to bring academia into the response. We need to bring all the partners that have expertise, that have opportunities to work together. And in order to do that, it means a different way of working for us. And really that's what we're trying to do in the new pandemic hub in Berlin, creating a space, a collaborative space that is welcoming, that is accepting, that has a role for WHO, but a role for everyone else to come in and work with us, to think with us about the future. And I'll end by saying, I started by saying that when you have a health security event, you need an organization that focuses on health security. And there's no better example of that than our colleagues in Rwanda, led by my brother Claude, who leads the Rwanda Biomedical Center, that pulls together all the expertise, the skills. When you come to Rwanda, you don't hear about a HIV surveillance system, a TB surveillance program, a COVID surveillance program. You hear about one center that has the responsibility for preparedness and response. It's a perfect model for the continent. It's a model that we are trying to really advocate for every country to have, to pool together so that we can best manage our scarce resources in delivering the response we need in every country on the continent. Thanks.
Thank you, Dr. Chikwe. That was a fantastic review and a forward-looking framework for how we might continue to learn and put new systems in place. And I think we're already just 2 speakers in, starting to hear some common themes here, which is great. The importance of national response that's coordinated, that has some clear organization. I'd like to, as we go, tease apart issues. We've hit on this idea of coordination, and we've hit on this idea of governance, which are not the same. So have we gotten to a point of being able to say who's in charge, which is different than are we coordinating well? And hopefully that's an area of tension we can come back to, because I think it's going to be an important area for us to figure out at multiple levels going forward. With that, let me turn to Dr. Magda. You've had experience as a health minister. You now lead an Institute for Global Health and Development. You've seen what's happened from COVID to other health needs. Would love to hear your thoughts on the path forward, especially around integrating into health systems, primary care, and pandemic preparedness.
Thank you for giving me the floor. I hope you can see part of me. Distinguished audience, it is a pleasure for me to be joining this group of eminent speakers, even though they're all men, and I hope next time I'll have a sister to join me as well. Thank you, thank you, thank you. We need, I know they tried hard to have more women, but they need to try harder. I was also going to say that I thank the organizers for inviting me and giving me the opportunity to share what have been the negative impact of the COVID-19 on some pressing health needs on the continent, and share some thoughts on the path forward to integrate primary health care with pandemic prevention and control. So if we start with the impact on the health needs essential interventions, as you have all come to know, we have all come to know, the number of people who died as a direct or indirect consequence of COVID-19 was much higher than the initial numbers that we had. So the excess mortality, the global excess mortality, is much, much higher, around 20 million, as you have heard. But Then when you look into how the share of excess mortality is distributed across the different income groups, high-income countries, low, middle income countries, you will see that actually low and middle-income countries have a very high burden of mortality as a consequence of the COVID-19 pandemic, which is a result, of course, of lack of access to essential health services. Combined, the developing world had a total of 83% of excess mortality compared to the reported number of COVID mortality. Most countries on the African continent belong to the low to middle income categories, so the burden of mortality has been quite significant. So before diving into the impact on health needs, I would also like to share this slide on the overall impact on poverty and education. According to the World Bank, the COVID pandemic caused the first historic increase in global poverty in at least 25 years, reversing decades of reduction in global poverty. The World Bank estimates that the number of people living in extreme poverty increased by 11% in 2020, with 90 million more people living in extreme poverty in 2020. We need to continue watching these numbers and its overall impact on health in Africa, because those people who have plunged into poverty, into extreme poverty, it will take hard work. It will take several years before they can go back to their initial living levels before the COVID-19. On the right, there is a graph that shows the share of learning poverty. And the number of children in learning poverty increased from 53 per 100 prior to COVID to 63 per 100 children post-COVID-19. The pandemic had a huge impact on child immunization, with an estimated 25 million children having missed out administration of life-saving vaccines. WHO and UNICEF estimates that this has been the largest backslide in vaccinations in 30 years. The consequences of this large pool of unvaccinated children are to be monitored, with some countries already reporting outbreaks of measles, and we should expect an increase on child mortality if urgent measures are not taken to redress the situation. Similarly, a systematic review and meta-analysis of 2021 concluded that global maternal and fetal outcomes have worsened during the pandemic, with an increase in maternal deaths, stillbirth, and maternal depression. When it comes to the impact on tuberculosis, the latest WHO report, which presents the estimated TB incidence rates for 2021, has this self-explanatory map where the darker shades of green or blue, depending on how we interpret the color there, the darker shades represent the highest incidence per 100,000 population per year. And as you can see, for the African region, there was an increase in case notifications of people newly diagnosed with tuberculosis between 2020 and 2021. Although an increase in notifications is a good indicator because it means people will be put on treatment, the fact that these are newly diagnosed people says a lot about disease transmission within communities, within lockdowns, and households with a large number of people. On the graph that is to your right, you will see that South Africa, Kenya, and Angola had the lowest reduction in case notifications in 2020 and 2021. On these other graphs here, you can see, I hope you can, a picture of the negative impact on tuberculosis in some countries in our region, namely Sierra Leone, Uganda, Congo, Lesotho, and Angola. When it comes to HIV/AIDS, this is still tuberculosis. This is tuberculosis as well. HIV/AIDS, the bars represent the last bar. So the last two is 2020 and 2021. It represents the number of HIV tests in Eastern and Southern Africa. The reddish is Eastern and Southern Africa, and the greenish is West and Central Africa. You can see this is again from the UNAIDS reports. For 2020 and 2021, there has been a decline in the number of HIV tests performed in East and Southern Africa. The number of people receiving antiretroviral therapy decreased in 2021 in West and Central Africa. This is the graph. The right one is for East and Southern Africa, and the left one is West and Central Africa. And this decrease in the number of people accessing ARVs is even more accentuated in East and Southern Africa, although the decrease started prior to COVID-19. Mental health, just to touch rapidly on it, before mental health, this is the negative impact on neglected tropical diseases. There has been a 34% decline in NTD treatments in 2020 compared to 2019. And there is some recovery in 2021, but only a 10% increase from there. This is also to show the setbacks in NTD's access to treatment. Mass distribution of medicines were certainly not possible as before, and that as a consequence, we could see a decrease in people, the number of people accessing medicines for treating neglected tropical diseases. WHO estimates that there has been an overall increase of 25% on the prevalence of anxiety and depression. We presume that this was also the case on our continent, even though we have different ways of perceiving and living anxiety, depression, and mental health conditions. For the sake of time, let me now move to the second part of my talk, which is the question, what is the path forward to integrate pandemic response into primary health care? Primary health care underpinned the Health for All by the year 2020, an aspiration goal which was adopted at an historic conference in Alma-Ata in 1978 and then recommitted to in 2018 in Astana. I think we all agree that the goals, the principles, the strategies of primary health care remain the essence of public health and would put us on the path to universal health coverage, more resilient health systems, and pandemic-proof systems that will prevent us from living the catastrophic situation we had with the pandemic, the COVID-19 pandemic. I think also we should recognize that progress has been rather disappointing in terms of implementing the primary healthcare strategy after nearly 5 decades of implementation. We have had, according to my view, our health systems have not been built with the needs and priorities of our communities and countries at the center. We have not integrated health determinants into our approaches to better health and have not been accountable to the people we serve. Most importantly, all the attempts to implement primary healthcare strategies failed to put equity at the center. In my perspective, this is due to several factors that turned primary health care more into an emotional attachment than into a pragmatic way of providing promotional, preventive, curative, and rehabilitation services to the people most in need, or the people who need them. In my perspective, and to conclude, the path to integrate pandemic prevention and preparedness into primary health care depends on how well we seize the opportunity of the COVID-19 pandemic to address the barriers created by the current global health architecture and its governance arrangements. Dr. Chikwe just alluded to the efforts WHO is doing to review, revise, and improve on the governance of pandemic prevention, preparedness, and response. The governance of the current global health architecture is something that we really need to intentionally work on. If we don't, there will never be a primary healthcare strategy, approach, and principles that will serve the interests of our health systems. So, first of all, is making sure that the barriers created by the current global health architecture and its governance arrangements, by the siloed and fragmented working and top-down styles of global health initiatives, and the insufficient investment from governments. That's why we need a new public health order in the global health that is really global and ceases to push people behind. Very often, we talk about people who have been left behind. And we should be talking about people who are being pushed behind. Women have been pushed behind in leadership roles. Young people have been left behind. Communities have not been around the decision-making tables. This is what needs to change if we are to turn the crisis into opportunities and build sovereign and resilient health systems to ultimately achieve universal health coverage. I thank you.
Thank you, Dr. Magda. Fantastic tour de force of helping us understand all of the implications of COVID and also ending on a forward-looking note of how we can actually learn from this and start to move forward. Thank you also for making sure we remember that equity should be in the middle of all of this. And thank you also for reminding us about gender equity here. And you're right, we tried, but you're right, we should try harder. So point well taken. Again, great progress in this conversation. Let's keep going. And I want to bring in Dr. Solomon next, who's at the MasterCard Foundation, which of course has a major collaboration with the Africa CDC. And oh yes. Step down now. Thank you very much, Dr. Ahmed, for your time here. And now let's go back to Dr. Solomon, who's going to talk a bit about global and regional partnerships as well as lessons learned.
So, thank you. Thanks for having me here, first of all, and felicitations for everyone for being still awake at 6 o'clock, especially for those that have traveled long distance and are struggling with jet lag. I only have 4 slides because I actually know that I'm the one, or this team is the session that's standing between you and the energizer that follows. I'll spend more time on the last slide. The first 3 are just basically telling you what you already know. And the last one is a very, you might say, very simplistic way of really talking about partnership. But you'll be amazed how many times we miss on those simple principles of engagement and how many faux pas we've had around the world throughout this pandemic. So as far as my first slide, partnership already comes with its own definition, so this is not particularly a defining slide, but a reminder that, you know, the last time we saw this, it was 100 years ago. And the world did not have any blueprint on how to come together to respond for this. And it has made a lot of mistakes, and it has also made a lot of amazing successes. Bringing out a vaccine within 8 months of actually sequencing the virus was an amazing accomplishment on its own, in addition to many, many other endeavors that have happened even on our own continent. Things like, the genomic sequencing going from literally 1 or 2 countries on the continent to perhaps all of them currently. But we've also experienced a fair amount of significant challenges in testing, diagnostics, treatment, and delivering vaccines and a timely vaccination opportunity, which again demonstrate the vital importance of partnership, and more importantly, the kind of partnership we need in the future, because we keep getting reminded that it's not if it happens again, it's when it happens again. So what the partnership should look like. I think that the core thing and what this slide is trying to really put forward in front of you is the fact that we have to have an Africa agenda supported partnership. By its mere existence, a partnership usually takes under its core DNA goodwill, willingness to come together for a greater purpose. But the principles around that is where we've had a little bit of challenges. So this is a slide where I've been able to kind of like put in place some of the things that we hope would be reflected in the next pandemic or the next small epidemic, as Ahmed was saying earlier on, to not be left to deal with the small ones and only come together for the big ones. Again, so I'm not going to kind of read the slide because I said I promised I was going to spend a little bit more time on the last slide, but all to say that this is not just about me coming up here and saying this is what partnership should look like, but in a sense, my next slide will talk about one investment that we put in place as the MasterCard Foundation that kind of try and upholds those values and principles. To most of you, the Saving Lives and Livelihood grant is something that went to the Africa CDC, the African Union, to kind of address some of these what are considered the challenges or the faux pas that I talked about earlier on. It was meant to address vaccine inequity. It was meant to support system investment. I'd really invest in the engine that we know as Africa CDC to be able to respond and deal with upcoming challenges or crises. And after all, also to recognize, and this is one of the big points, to really recognize that there is capacity on the continent that should be harnessed and that has been seen over the pandemic, over the 2.5 years that I've had the benefit or pleasure to coordinate my former employer's response, and really seeing the actions like AVAT and PACT and the Africa Medical Supply Platform that have been put together as a Africa-owned, but also hugely collaborative to what exists out there as great entities that have put us through what we consider to be perhaps the late or ending phase of COVID currently. My last slide, you look at it and you're like, oh, these are really simplistic. But like I said at the beginning of my email, my presentation, there's these principles that I myself and colleagues I work with, even some on this panel right now, I've had the great pleasure to work with Chikwe and director of the RBC as well, on many sessions where we brainstormed about what went wrong and what are the good things that we can actually harvest as exemplars. So we have it straight and invest in it as we move forward with this pandemic hopefully being over altogether, and that's another definition out there on when it's going to be over. But just to spend a little bit of time, on these 5 bullets or 6 bullets that I put here, global good partnership instruments should be based on the principles of inclusive design and mutual accountability to eliminate crippling power dynamics. This has been mentioned again and again, even in today. The power dynamics have been crippling, and these are some of the things that we should pay attention to. Planning phase should include the continent, should include anyone that we're partnering with, and enable successful implementation. True partnership by its nature is democratic, of course, but should be measurable and representative of the true need, i.e. the Africa agenda that I talked about earlier on. Humility, again, listening, co-creation, and respect should not be overlooked with the haste of actually trying to come up with something to help. To that point of me saying it's all goodwilled, but goodwill that's not well channeled or inclusive becomes compromising. The partnership's successful measurement should not stop at fund mobilization. It is not the end of our effort. In fact, funds that have been raised that are not tracked for impact perhaps could be more detrimental than no funds at all. Almost last one, partnership should be about resilience, sustainable capacity creation rather than dependency. We've seen this again during COVID as well, and we hate to see it again now that we've had a blueprint, now that we've survived one, and we feel like we're better prepared for the next one. And again, it should focus on inequity alleviation, as well as the mitigation of different standards. We've seen them. This is not the forum for us to call them out, but necessary for us to be reminded by it as we move forward and try and tackle the next one. I thank you on that one, and I'm happy to elaborate on anything that was not across. Thank you.
Great, thank you, Dr. Solomon. I think, again, fantastic to hear some of the lessons learned and how we can codify this art and science of partnerships, which we've all talked about so far, and we've heard about the importance of collaboration and the WHO framework, and bringing some of that to life is really helpful, so thank you. For our last speaker to bring into the conversation, let me turn to Professor Christian, who's going to help us to think about lessons learned and future priorities as they relate to a really important field of genomic surveillance.
Hello? Thank you. Probably just really go straight to the point and mention some lessons learned, especially, and then some reminder that this pandemic brought to the fore, especially for Africa. One thing that comes very clearly is the fact that, like other speakers, Africa is over-reliant and over-dependent. It is obvious that from the 1960s, when the African countries gained their independence, we really did not think about standing on our own, but rather, keep depending on our previous colonial masters. And as such, we saw a continent entirely dependent on the outside at the beginning of the pandemic. Even simple diagnostics we could not produce or even try to attempt to. We had to wait for the outside, the external world to give us. And that really makes us very vulnerable. So my question is, how do we end this kind of vulnerability going forward? Secondly, it is also very clear that in front of a crisis, multilateralism and international cooperation, which is something that Africa depends a lot on, can dissolve. And as a continent, how do we go around this kind of dependence? Thirdly, the need of data is very important. We need to work very hard going forward to generate valuable quality data that can enable us to make the right kind of prediction. We saw at the beginning of the pandemic where models, based on false or wrong assumption, predicted that within the first 6 months of the epidemic, 70 million Africans were going to be infected and over 3 million people would die. As a continent, what can we do to generate quality data in order to be better, to predict better and plan better in the future? But really, one thing that I also saw in the pandemic is the fact that inequity in the world is very strong, and Africa really stands to lose a lot in the whole process. I will be veering to genomic sequencing or genomic epidemiology and how we use genomic on the continent. We all agree to share data and share genomic data. But then, the data were used to develop countermeasures, diagnostics, vaccines, and these IPs. At the point of sharing the benefit of data sharing, we're told that we don't deserve those. We don't deserve to benefit from the data that we shared with others. How can we prevent this from happening in the future as a continent? But there's some glimpse of hope ahead. We saw an Africa that was resilient, and we saw that Africa can learn from the past mistake. I guess from the Ebola epidemic in West Africa, the African head of state in their wisdom established the Africa CDC and also really supported the establishment of national public health institutions. The national public health institutions, the Africa CDC, and also the Academic Center of Excellence, funded by many African governments across the country, came together and they saved the day because they collaborated, they cooperated, they communicated, and they were able to help the continent overcome this challenge. And all of this make me to believe one thing, that if Africa come together, as we've demonstrated during this pandemic, we can be very key players, not only in generation of knowledge, in acquisition of knowledge, and we can use knowledge to earn our rightful place in the community of nations. And finally, just to illustrate the problems, Africa has to think about, investing where its mouth is. We need to invest the money in our challenges and in our problems. Because if we don't do that, nobody's going to come to our rescue. As the pandemic has shown us, we are on our own. Before thinking about partnership, before thinking about others coming to support and help, we need to really think about solving our problems ourselves. So looking into the future, I really want to say that multilateralism will always be very crucial, in responding to epidemic. But Africa will have to benefit for the advance it made. You can see what happened for COVID-19 and what is happening right now in the DRC, in Uganda, in containing the present Ebola epidemic over there. We've done a lot of progress, but we really have to think about, in order to benefit from those progress, we need to have to rethink our disease surveillance system, whereby we need to configure it toward self-reliance instead of waiting for help to come from outside. And in so doing, I have like 5 steps to propose going forward. And this will be built around genomics and how the continent was able to leverage it, and how we could take this forward to a point whereby we could rather, instead of becoming a continent that is reliant or dependent from the outside, to become a powerhouse for knowledge and a powerhouse for generating countermeasures for the rest of the world. The first step is the fact that we are now, as a continent, faced with a very stark choice. Because of the biodiversity that this continent is enriched with, Africa is not just endowed with minerals and natural resources. Africa is endowed with very powerful biodiversity. And as part of that biodiversity are microbes, are viruses, and are pathogens. Whether we like it or not, our ecosystem is the ideal environment that is prone for epidemic and those epidemics who have pandemic potentials. The question is, how can we turn these so-called challenges into opportunities and change the world? And I believe that genomics is the route to go, but we are faced with a stark choice. The leaders of all the 55 African countries will have either to commit the resources for health R&D, or together we will all perish. There is an Abuja declaration that says 15% of African annual budget of every country should be invested into research. We're still struggling with countries reaching 1% or 2%. We need to change our mindset. We need to understand that the future and the future of Africa is intricately related to R&D for health, especially on the continent. And in principle, African countries could really build on the astonishing gain that they've made on disease surveillance, in order to really build a model that could be a model that can be emulated through the world. And this time, we can strengthen what I call African-owned institutions. That is the Africa CDC, the National Public Health Institutions, and the academic centers of excellence that will, what I call translate, genomic data into countermeasures. We saw an African during the pandemic being the first to identify things like variant like Omicron, identify the Delta variant. We saw African institutions moving very quickly, developing point-of-care, point-of-need diagnostics, but their effort stopped right there because there was no support to take it further. We saw African institutions innovating in many ways, and we did not think about supporting that. If that effort was put in place, if the resources were put in place, we could change the tide, we could change the dynamic. We could actually become producers of new knowledge, and we could actually turn Africa to that very powerful powerhouse that we think. There's a need to accelerate translational research and innovate and development on the continent. Currently, we're importing 70 to 90% of drugs. We're importing 99% of vaccines. It's not something that is acceptable going forward. Is it that there's no capacity on the continent to do this? The answer is no. Between the brains on the continent and in the diaspora, Africans can really develop a lot of the things. And this pandemic has demonstrated that given the resources, Africans can actually lead, as we've seen, for instance, for using genomics to actually respond to epidemics, or to this pandemic. Thirdly, I will say that government philanthropies, we have the African Exim Bank, we have the African Development Bank, we have the private sectors. There should be intentional investment into funding with focus on diagnostic therapeutics vaccines for not only infectious disease, but also non-communicable disease, because obviously that is also another pandemic that will be coming our way. And this investment should be made around all the sectors, national public health, lab, academic, institutions, in order to, build the necessary platforms that could lure back all the Africans that are in the diaspora and that could come back and basically sustain this effort. There is a need to set up early warning systems that could help the continent to respond to the list of epidemics, but also protect not only the continent, but also protect the world. That should be Africa's contribution to the global health security. There is a need to build what I call a centralized governance, where we could use genomics as a way to actually strengthen that centralized governance, that is understanding the microbial landscape and using that as a way to actually develop the necessary countermeasures. That is characterizing the pathogens, developing the countermeasures before they come to us. And as such, I think, building an African pandemic preparedness response authority that will support Africa CDC, for instance, in its mandate to respond to epidemic will be very crucial. And that really can help, to help the agility of this organization. And this model can be built around like the European Health Emergency and Preparedness Response. That's, for instance, a model. But ultimately, what I see that is lacking on the continent is the ability to collaborate, coordinate, and cooperate. But we saw that in the context of COVID-19. We saw how Africa could make use of the little resources it has to respond effectively to this epidemic. We saw, for instance, samples from Somalia coming all the way from Somalia to Nigeria, being sequenced and sample getting back. We saw Rwanda, for instance, in the dark of it, sending sample to Nigeria, being sequenced and then sent back. We saw teams from Nigeria in the midst of the pandemic coming to Rwanda to support. We've seen that across during this pandemic. During this pandemic, if you look at the data from Africa CDC, within Africa, by Africans, we were able to train 54 out of 55 African countries to do testing and also to do sequencing. And these sequence data were very important to countries. So when I hear a lot of the time when people say, well, we didn't have a lot of tests, there was not a lot of testing, there was not a lot of data from Africa, I always ask the question that people should be rather ask the question, what did Africa do well in order to, to deserve, this positive outcome? It means clearly that going forward, we should learn from the cooperation that we had during this pandemic, working with national public health institutions, academia, and the private sector in order to, learn how to respond better to epidemics. Public health in Africa shouldn't be seen as the sole responsibility of National Public Health Institute, or National Public Health Institute shouldn't see themselves as the sole responsible to ensuring, public health response. It requires everyone, and we've seen it. Strong collaboration between national public health, academic institutions, and then other key players will be very important going forward. So therefore, I would suggest countries in Africa should think about cooperating, collaborating, communicating, and eventually coordinating their efforts. Thank you.
Thank you, Professor Christian. A fantastic overview of a path forward that's comprehensive and brings in intentional investments into areas like research and development, exactly fitting with some of the other areas we've talked about here. It's my great pleasure now to turn over this mic to Professor Claude, my co-moderator, to give his reflections on what he's heard so far and get us started with the discussion.
Thank you very much, Dr. Krishna. First of all, I was really delighted to really be co-moderating this session with you, and also to really thank all the speakers for really taking us through a very great and rich discussions around lessons that we have learned during our response to the COVID. So maybe let's give them another round of applause to really... So there are a lot of lessons that we've learned from our response as a continent. And if I start with the remark by Dr. Ahmed, where he really emphasized as leader of Africa CDC, where coordination was very crucial and very helpful in terms of really making sure that all states, so the coordination will start from the Africa CDC until the community. So I think we also hear that there is also a need for our own tools to really make sure that we don't really wait to be supported from outside. And this is also something was really reflected by Professor Appiah, where at the beginning of this pandemic, we had to wait for simple diagnostic to really come out of Africa. So again, he also mentioned about the need for a strong institution, strong national public health, and we would like to thank Africa CDC for really supporting country states to really make sure that we have very strong public health institute to really lead our response, but also prepare for the next pandemic. And my brother, Dr. Chikwe, really emphasized on obtaining rapid data, quality data, to really make decisions. And this need to be really obtained from a collaborative surveillance, which really include also other opportunities like genomic sequencing that also Christian Happy mentions. And again, for the support for other areas of lesson that we learned, we also learned that by Dr. Magda, which mentioned about how can we probably strengthen our primary health care to be responsive to our needs, the needs of our community, but also the needs of our states to be able to respond to the next pandemic. So let me now open the floor for some of additional discussion and questions. And I would like to start by our last speakers, Professor Apia, where you mentioned about how Rwanda, or how the continent would really invest in R&D. And we know that, and also over the day, over the course of this day, we have really felt the need of more research on clinical or critical public health issues, and especially research undertaken by African continents. So, Professor Christian, what changes are really needed to make this a reality, to really make sure that research are promoted within the continent?
Thank you. I do think that, as I said before, research and development shouldn't be seen as a luxury. It is definitely something that is highly needed. And if the continent understands that the future of this continent is linked to research and development, especially related to infectious disease and non-communicable disease, then we will know that, for the next generation, it is important to invest into that. And then the reason why I believe it's crucial to invest in research and development is the fact that if you see, for instance, what happened during this pandemic, within a new virus that nobody knew anything about, because of research and development, within 9 months, or 8 months, we had a vaccine. And thanks to that vaccine, the world is a bit safer. It shows really the power behind this. But again, I will draw it to something that I believe is very important. There's a huge divide between the rest of the world and Africa now in many ways. We're talking about diagnostic development, we're talking about therapeutic development, we talk about, vaccine development. We have an opportunity as a continent to use genomic, which for me I call the great equalizer, to level the field. And we've shown in this pandemic that we could use genomic to actually show the world how to do things. You saw the case in Nigeria where, for instance, Nigeria wasn't the first country in Africa to have, to declare COVID. But in a very powerful collaboration between Dr. Chikwe and I here, within 48 hours, we had the virus elucidated, and we knew exactly where that virus came from. And that helped him to say, well, we didn't have local transmission, it was imported, we knew exactly where it came from. But then with such tools, you saw in South Africa, that gave the confidence to people on the continent to know that they could do it. You could see South Africa leading the way with the Beta variant, you could see them with the Omicron. So that really helped a country like South Africa and then other countries to really start using that as an approach to contain that epidemic. But we need to go beyond it. Right now we're talking about just genomic epidemiology. We've got to be translational. And translational research will require that we go beyond just looking at the sequences, but we need to start using those sequences to create diagnostic, to create vaccines, to create therapeutics. So it is one thing to say that we are setting up platform for vaccine development on the continent, but vaccine development does not just work in those platforms. R&D is actually at the core, and R&D is important in order to create the vaccine, in order to create the drugs, and in order to create the diagnostics. So therefore, going forward, I think that's where the focus should be, and that's where the investment should be made. And when I talk about translational research, so we're not just talking about genomic translational genomics, but any other thing that has to do with, with measures and policies that can help us better contain, future epidemics and then create novel tools will be very central. Thank you.
Thank you very much, Professor Apia, for really telling us that we need to invest in our challenges. I don't know that you see the promotion of R&D is still our challenge in the continent. So thank you very much. I think this is a call for actions where we need probably to really invest in those challenges that we are facing. Let me turn now to Dr. Solomon, and thank you very much for all that MasterCard is doing to really promote this global and regional partnership to really, in some of the interventions to our response to COVID-19. And you really described a little bit about the partnership-driven response. And I want now to really hear about you, about how can we leverage capabilities and resources across the private sector to support this pandemic prevention, preparedness, and response. And what type of cross-sector partnership models hold promise for Africa?
Thank you. So thanks for the question. We recognize in either this pandemic or any crisis that happens on the continent that the problem is too big for just one entity to effectively address it. Along the terms of the same partnership, that collaboration word has been used several times over. So sharpening those abilities to work together for a common cause would, in short, for me, be the answer to having a successful response to anything. MasterCard put this investment in the Africa CDC, but that's not the only place, and there are many around the world that are equally investing in trying to bring about a network of responders, a network of agencies, a network of policymakers to fare anything and not necessarily wait for the next pandemic. Hopefully we'll be best prepared to avoid the next pandemic, the surveillance, the sequencing, the catching it, the containment, all of that we have at our disposition should come in play so that we don't have to have another one. I think I've kind of answered your question. The funding mechanism, I think you mentioned, it all depends. I think we've seen many models of funding opportunities coming together for the greater good. Some of them were successful, others were not. Planning for a pooled approach during a pandemic was also challenging. We've seen all sorts of different priorities in donor groups as well as countries during the pandemic because there was a prioritization situation there on how you would address it for your own citizens versus addressing the rest of the world. So I can't tell you what would be the best one. I would say that it should mirror the extent of the response that's needed. And in my presentation, I actually said, there's a lot of efficiencies out there that we should capitalize on. That's not necessarily fund appropriation. We kind of rush to saying how much money was raised for that effort without necessarily seeing how much capacity already exists and how much of it can be coordinated and harnessed. So over to you.
Thank you very much. I think funding is not an issue, but we need probably to really use data to really be able to identify the needs and also plan very well in terms of those needs. Thank you very much for those reflections. Dr. Magda, you probably share with us some of the data on the impact of COVID-19 on some of the programs like TB, tuberculosis, HIV, but also we have seen excessive mortality during COVID-19. And I know that's one of the main driver of this is also inequity of what that we have seen in our response. So I wanted to really also like to really hear from you on what the type of actions around the world which clearly failed in delivering on the global equity pandemic response, taking those lessons learned, and what are the most important and urgent actions we need to take to ensure a more equitable response for current and future threats to build our primary health care.
Thank you. That's a difficult question. Equity is a multi-variable composites kind of animal. You have economic, social, gender, different types of inequities. I think we need to start somewhere, and I think the easiest way about it is leveling the playing field when it comes to access to the minimum package at home, being able to put food on the table, sending children to school. That's where you start having a different way of going about your own life, realizing your opportunities. The graph on poverty, learning poverty, it's about children going to school but not learning anything and not being able to read and write. That's a major problem that we are accumulating for the future. It's a bomb that we are sitting on. And we can't address equity if we continue to have learning poverty, for example. Gender equity is something that we can do something about. Today we have more girls going to school than we had before. Probably the best transformation in our societies in several decades. It's still not enough because we still have child marriage, we still have female genital mutilation, we still have so many cultural barriers to that. But let's capitalize on the goods that are happening and then give girls, women the opportunity to get into leadership positions where they can influence what is being done, where they can be role models so that parents and other girls can see that if she is there, I can also do, I can also be. We have a youthful population in Africa, but we have huge unemployment rates. We need to do something about that if we are going to stem the drowning in the Atlantic. That means that we need to create job opportunities within the continent. We need to look into our economic, let's say, economic basics. The same way we are saying the global health architecture, we need to think about it and reverse it. Probably the premises under which we are building our economies need to be rethought so that we could do something different. And the resources that we have can better serve the continent. All this cannot happen without a political and governance ecosystem that will, of course, give us opportunity for progress and development. It is beautiful to talk about gender equity if you don't have the right governance setup in your country. But I think as much as the challenge can look enormous, we need to start somewhere, and I think gender equity is one of those. Education. We can't have better health if we don't address the challenges we have in education. And these are some of the investments that our governments need to do in order to address the widespread inequity. Now, when we look into the global south, global north inequity, that's a different ball game. Our leaders are right now in the US. They are meeting with the American leadership. And I think that's also an opportunity for addressing inequities that happen between the global north and the global south. So becoming more assertive about what our priorities are, how do we want to go about them, being clear about what we want, and being steadfast in terms of asserting our priorities, being coordinated, standing as one, I think will go a long way in making our continent transform itself, taking advantage of the current crisis, and then becoming a prosperous, the Africa we want that we talk about.
Thank you very much, Dr. Mada, for reminding us that we need good governance that sets clear priority, but also taking care of vulnerable population, including women and children. Thank you very much. Last but not least, my brother, Dr. Chikwe, I know that you have a huge experience in leading one of the national public health institutes in Nigeria, and from that success, you move on to be working under WHO. And we clearly experience some of the weakness in our public health institutes. And from the Dr. Ahmed, who said that probably we need to do more to build or to establish more national public health. I wanted to hear from you, and we know that over the past several years, it has become even more clear how important trust is for the public health. And during the COVID-19, we have seen a decrease in the trust in the institutions and also in trust in public health over the time, worsened by the pandemic and inequitable and also ineffective responses. How do you think we, as head of National Public Health Institutes, can build trust in public health going forward?
Thanks, my brother Claude. You've asked me the most difficult question on how we can build trust. Let me start by a little anecdote around the role of National Public Health Institute. This is a real-life story. At the beginning of the pandemic response in Nigeria, let's talk about diagnostics. When it became obvious that we could use diagnostics for PCR using gene expert equipment to rapidly do as close to patient as possible. All the gene expert equipment in Nigeria and in many other African countries were managed by the TB program. I had to go to the TB program to negotiate the use of diagnostic equipment that were procured and managed by the TB program. The TB program in Nigeria told me, listen, most of our gene experts are managed by a partner. So I had to take permission from the head of the TB program to go to the implementing partner to get access to diagnostics to manage a pandemic. So most of my time, to be honest, through the beginning of the program was on negotiating access to people, to infrastructure, to support, to resources domestically and globally. And to do that, you need trust in the local environment, right? In a complex country like ours in Nigeria, you need trust between the federal and state levels, and you can't really build that during a pandemic. So I think the biggest thing we need to do now, if I can call this already, in the inter-pandemic period, is to really focus on building. And not just training and building people, but building trust around the people. Because when you need them, when you need trust, it's not the time you build it. You build it before. What the example Professor Happy gave is very important, because very often, and even through this pandemic, even through this conference, we're focused very much on Africa, and it's right. We need to build African institutions. But we're also part of a global community. And it's important to assert ourselves in that global community. WHO is a member state organization. It's not a partner. So we need to be strong members of a strong member state organization like WHO and build trust in a global community. Yes, it's not a surprise trust is broken, and we have a big challenge, and that is not only within the continent. But it's up to us to really focus on how much do we have in common and how much divides us, and really focus on how do we build on that we have in common. And it's not only between countries, it's between public health agencies and academia, between philanthropy and government, between the private sector and the public sector, all these kind of categories that we put ourselves in order to define who is more important when. If we change the narrative from saying, I'm more important to you than you, to how can we find common areas of interest that are mutually beneficial for all of us, then maybe we can make progress. And I think the theme generally of this conference, that we have not built sufficiently on the opportunities to collaborate globally, is a big challenge. And very often we think, okay, Africa and the rest of the world. I'll tell you, to be honest, in Nigeria, we are not collaborating sufficiently with Chad, Cameroon, Niger, Benin. These are our 4 neighboring countries. And I can say for free, if we are not collaborating sufficiently among ourselves, then maybe we should be a little bit more humble in criticizing our ability to collaborate globally. So I think we should generally all look at ourselves. In order to build trust, we all need to look at ourselves first and say, listen, where are the opportunities to build the relationships that matter among whatever communities we're working with, and start today. Let's not wait for the next pandemic and try and build it during a crisis.
Thank you very much, Dr. Chikwe, for really telling us that we need first to collaborate among us and also look at all those opportunities and really build that trust among our fellows. So thank you very much. I think now we have a few minutes for a few questions from the audience. So I'm not sure if there are any question that you'd like to ask to our panelists, our speakers. There's a microphone going around, so please feel free to ask questions. So we will take maybe 5 questions. I know that the time is not on our side, but let's give opportunity to really hear also from the audience with 5 maximum questions. Thank you. Microphone, so we have a question here. And so ladies there, second lady there, and Prof.
Thank you, Chair. It was really a pleasure to listen all these fantastic talks about our future, practically. And I wish we had more time to ask more questions. But unfortunately, I will limit my questions to 2 of our esteemed presenters here. My first question is to Prof. Christian. Really, thank you very much for bringing that idea of our, the point that you mentioned about our rich biodiversity and our ecosystem we are living in, and more beyond about this biodiversity and our vulnerability, while it is still an opportunity for us. Unfortunately, it will still continue to be our vulnerability because there is no governance, protection, administration and management of our ecosystem and biodiversity. So my question to you is, if you can give us some insight about how we can harness, protect, and govern our ecosystem and our biodiversity so that we can export it in a way that can be more opportunities than vulnerability. This is my first question. Thank you very much. My second question is Dr. Magda. Thank you really very much for that. I think as a health emergency in Africa CDC, it is really my concern to see primary health care and essential services are the big compromise we jump in during our health emergency response. But still there is no way out now, I can see in the near future, because still our health system is very much stressed in. So if you can give us how we, as Africa CDC, as national institutes, we should really make ourselves or strategize in a way that can really help without much compromise of our health essential services and in a way that we can handle our outbreaks. Thank you very much.
Thank you very much. Maybe we can take 3 more questions because the 2 questions that I've been asking.
Good evening, everyone. I have to stand because I'm short. So I'm Caroline Wangamati from the Coalition of Blood for Africa. But just call me a vampire, just the blood advocate. And my question is to the panel. We're discussing the future of Africa. We're discussing our preparedness for pandemics. We're talking about preventive and being able to react. And I stand here a little bit disappointed because in the entire program, when I look for the 3 days, I'm not seeing blood anywhere. I don't understand how we plan to handle everything that we're talking about if we're not discussing blood. Whether you talk about the mothers that are hemorrhaging to death, whether you're talking about using plasma from recovered COVID patients to treat COVID, whether you're talking about Ebola, which is a hemorrhagic fever, whether you're talking about anemia in our children, whether you're talking about oncology patients that need blood components. When are we going to discuss blood as Africa? When are we going to prioritize blood as Africa? Why is the new public health order not having blood in the agenda?
Thank you very much, Caroline, for this question. So, yes.
Thank you. Francis Kakoza from Infectious Diseases Institute, Makerere University, Kampala, Uganda. So thank you so much for the presentation. I think my question is about the National Institutes for Public Health. From the discussion we have had, how do we fast track building their capability and capacity to be able to conduct research during outbreaks to inform public policy and action? Thank you.
Okay, thank you. I have one question and one comment. My question is related to the National Public Health Institute, and what is the relation? I know the structure and inside the Ministry of Health, it is different from one country to another, but I'm talking about the relationship between the National Public Health Institute and the preventive branches or department inside the Ministry of Health, when the preventive sector inside the Ministry of Health doing everything related to until the field work, everything, preparedness, response, everything. Okay, for what is the relations? Do you recommend the National Public Health Institute to be structured to put only strategy, coordinate the activity, or to implement the activity itself? This is the one. My comment regarding to when I'm talking back to the 2009, the pandemic of H1N1, and after that, the WHO formulated the IHR review committee in 2010. Okay, and what is the lesson learned from the past pandemic? And after that, in 2012, there is a formulation of PEEP, Pandemic Influenza Preparedness, from 2012 until 2015. This is the idea of PEEP. It is benefit sharing, virus sharing, and benefit sharing. What has happened, as you all know, in the pandemic of COVID, it is the IHR 2005, it is insufficient for prepare and respond, okay? And we all know that most of the country, okay, suffer from the deficiency, suffer from equity, not only of the vaccine and of the diagnostic kits, and of treatments. So I totally agree with your all thoughts for the continuous international collaboration, partnership, and build the trust between all of the continent and all of international health work, or of organization working international health. Thank you.
So thank you very much for those great questions from the audience. So let's turn on to the speakers to really provide some feedback or comments on those questions. So the first question was addressed to Professor Harpia to really elaborate more on how can we turn our biodiversity and vulnerability into an opportunity.
As I said before, there are opportunities in leveraging our biodiversity. For instance, if you look at pathogens that do have epidemic or pandemic potential distribution across the globe, about 70% of it is concentrated in Africa. So the question is, why are we not leveraging those pathogens to create diagnostics, to create vaccines, to create therapeutics? That's the only way we can do that, and the only way to do it is actually to focus on R&D and to invest into that. Because you look at the situation today, we have the Sudan strain of Ebola in Uganda. Where is the solution? Or we talk about the vaccines that are being developed for clinical trials coming from. These are, if the right investments are made, the solution should be found locally and not imported. So we're having another situation whereby you have a problem, and then the solution is coming from outside, yet you are the one with the raw materials. So the reality is that the raw materials are here, and we need to leverage the raw materials to, I always say that Africa deserves to be in the driver's seat when it comes to providing solutions to infectious diseases, because those pathogens, those microorganisms, are part of us, are part of our ecosystem. It's really not a good thing that the solutions are being provided from outside, yet we live with it. Now, the question that I asked during my presentation is it that we are not capable of providing the solution? The answer is no. We do have what it takes to provide the solution. What is the problem? We really need to start putting the right investment, focusing, putting our money where our mouth is. We can't afford to keep waiting for help to come. If we have not learned anything from this pandemic, if we've learned anything from this pandemic, is the fact that we can't afford to keep waiting for help to come from outside. We need to develop local solutions to local problems. And I see no reason why Africa should be the champion. Because look, it takes barely 36 hours for anything that happens in any remote place in the world to find itself in the biggest financial centers in the world. If that center is Africa, then we should be the one providing solution. We should actually be the gateway or the shield for the rest of the world. And for that reason, let's invest in R&D, because we don't have to export only oil, or we don't have to export all the minerals that have been extracted on the continent. We should be exporting vaccines. We should be exporting drugs. We should be exporting diagnostics if we put our resources where our mouth is, or our mouths are. Thank you.
Thank you very much. So there was the question on the blood, safe use of blood. I don't know if anyone wants to weigh in. Yes, Dr. Magda. Yes.
Thank you. Before I talk about the blood, there was a question about how we could introduce primary health care as a strategy to guide our response and strengthening our health systems. I think the example that Chikwe gave about the gene expert machine that belongs to the TB program, and then you have to negotiate with the program manager, then you go negotiate with the partner. It's one good example of why it is difficult to implement primary health care in our countries, because we have siloed initiatives that don't allow cross collaboration. I know very well what he's explaining. I had to, it goes to the level where the people who install the gene experts will make sure that they don't go, you need it in the highland in my country for the tourists to be tested before they get into the plane. They will not go because the gene expert machines belong to them. It goes to that level. Until we sort out these problems, forget about primary health care, because it will continue to be, this belongs to me, this vehicle belongs to me. We will continue to have fragmented health systems. When the crisis occurs, we blame everyone, yet we had the power to solve the problems. Going to the blood issue, again, it's part of the problem of primary health care. If we sit down and we look into our needs and priorities, we make the decisions about what should be our priorities. I think blood will not be forgotten. If you look at the situation of surgery, anesthetics in our countries, it's appalling. You'll cry. If you look at the number of surgeons we have, the lack of proper theaters, the conditions under which people are operated, you don't want to be sick. Where is it as part of our priorities? So we really need to make sure, and this is not about, I think, intra-country collaboration, intra-continent collaboration is not preventing us from doing global collaboration as well. But we just need to be sure about what our needs are, what our shortfalls are, to be able to take advantage, best advantage of the global collaboration. And just to conclude, to say multilateralism is so important that I don't think it's a question of being or not a member state of WHO. We have to rely on WHO. We need the United Nations. We need that global stage for countries to be able to talk, to dialogue, and then to find ways of bringing some sort of peace to the world. Otherwise, it could be worse. I just wanted to make sure that we, at least this is my perspective about this. Thank you.
Thank you very much, Dr. Magda. And we make sure that we include the issue around blood in our next conferences. Thank you very much. So, there was a question around the National Public Health Institutes. How can we really build capacity of our people to do research during COVID-19 or during any pandemic to really inform all our actions? And also, how can we really make sure that there's a coordination of our activities under national public health? Probably I can turn this to Dr. Chikwe and anyone who wants to really provide additional comment on that. Thank you.
Thank you, Claude. If you were not the chair, I would have done this back to you, actually. But, you know, my perspective on this really is when you talk about national public health agencies or institutions, sometimes people look at it in different ways. But the key thing about this is that we want a single accountability framework for delivery. If I were in Magda's position as a minister, I wouldn't want, if I need a rapid response team, I'm calling someone. If I want to send a sample to a lab, the reference lab is somewhere else. The EOC is managed by another department, you know, so that we have all the functions, but they are spread out through 15 departments, agencies, and ministries across the landscape. I would want to hold someone accountable for delivery. So if there's an outbreak, I know I can call a director of an institution or agency, and it is his responsibility to have prepared his team to understand that a lab needs to have a supply chain. That supply chain needs to have been ready. If a team needs to be deployed, it's deployed. If they need to work in an EOC, they're coordinated together. So really, this is the concept. So I don't want us to leave here that we need to go and build a new agency. It's every country needs to decide what is its accountability framework for delivering on health emergency preparedness and response. If you reflect on my institution currently, the World Health Organization, prior to the West Africa Ebola outbreak, we had the teams doing everything the current emergencies program in the organization is doing. What changed after the Ebola outbreak was a new program was set up called the Emergencies Program. And all those things around response EOCs were put under an executive director who had the responsibility that once there's an incident, a risk assessment is done, the event is graded, based on that grading, a response capacity is defined. And that now happens routinely for every response. And many institutions have taken that up. And so the lesson, I think, from this discussion, whether it's research, whether it's EOCs, whatever function is, do we have a single accountability mechanism? And if a country decides, listen, I don't need a new agency, I can do this within the ministry and do it well, then all well and good. But the key thing for me really is health, emergency preparedness, and response is not something that when you're called in the middle of the night that, listen, I have a suspect Ebola case, you start thinking about how do I call my director for laboratory services, how do I call my director for risk communication. All of those need to be already organized in a framework that will deliver. And Chair, just a final comment on my brother, the Honorable Minister from Egypt, is the changes, I think the changes in the IHR and the governance frameworks are very important. It's a reflection of us as a global community looking at the tools that we have. And you're right, after each big pandemic, there have been changes. Right now, the IHR processes are being discussed again. There will likely be changes to them depending on what our member states ourselves decide to bring in. But I think the key thing is, yes, we need these legal instruments to define what we do. But to me, to be honest, the most important is what we do even without the legal instruments. What is the level of trust and response and diligence that we are carrying out in our work? I hope, and in a way that's kind of what we're doing in the new hub, that to build a new mindset around collaboration that doesn't depend entirely on legal instruments. Legal instruments should be the last bit of the pie, but I hope that we get into a mode of constant collaboration that will lead us to getting responses improved all the time. And as we work together, we learn from each other, we begin to trust each other, and really that's, if I can take one of the biggest successes of Africa CDC, is the opportunity it has created for us to come together and learn together. And as WHO, we're very supportive of that, and we'll continue to strive to work together with Africa CDC to achieve that.
Thank you very much. I wish we could have time to continue the discussion, but we know that all the speakers are still around, and also may come back to also some of the aspects of this discussion during other sessions for tomorrow and after tomorrow. So I again invite you to be really active in participating in all those sessions and find those some other answers to question not asked. Thank you very much, Minister of Egypt, for your contributions. So with that, I would like to turn the microphone to my co-moderator to provide or to give some closing remarks for this session.
Thank you. And just given the time and how rich this discussion was, I won't try to do it justice by trying to summarize, other than to just recognize how important this topic is and making sure that we learn the lessons from the last several years to apply urgently to some of the outbreaks, some of the emergencies that we're facing, but also recognizing that almost every aspect of our health system, almost every aspect of our economy has suffered, and we need to think about how to rebuild, and trust is central to that issue over time. So thank you all for such active participation. Thank you to our esteemed speakers, Dr. Ahmed, who was here earlier, Dr. Chikwe, Dr. Magda, Dr. Solomon, Prof. Christian, and certainly Prof. Claude for your co-moderation and taking on the hard part of figuring out the hard questions here. Thank you all. Great way to finish the formal sessions on the first day, and lots of food for thought to take into tomorrow. So thank you all and have a good evening.
Thank you to our fantastic panelists for closing out our opening day. Everybody, don't forget to use the hashtag as you use it on social media. And you are invited to a cocktail this evening right downstairs by the square. So please go down, enjoy the rest of the evening. Shuttle services will start at 8:30 back to your hotels. We'll see you bright and early tomorrow morning at 9 a.m. Have a good night.